Who's that?
Medical student.
Who's that?
Medical student. Oh, that's a saying.
Why is Gemma that?
Because she is logged in. Okay, so I'm just going to get the presentation now. Yeah, so can everyone see the presentation on their screens? Just want a yes or no. Yeah. Can you see it?
Yes.
Okay, very good. Okay, so we are going to talk today about recurrent miscarriage. So this is not a topic of my choice, but it is something which Helen Marvel wanted me to speak about, just to understand more about recurrent miscarriage, what it means when you decide to investigate. But obviously, as a nursing team and as a unit, knowing more about recurrent miscarriage will help guide us answer questions, because obviously you see new patients in the clinic and there are so many women who come concerned that, oh, they have lost one, two, three babies, and they are concerned that something needs to be done about it, or they need a specific type of reassurance to help understand what's happening, why it is happening. Because obviously the most important question which everyone asks is why it is happening with me again and again. The doctor has investigated everything. Sometimes some investigations are done. The investigations have not found out any reason most of the times. And obviously, it is a traumatizing as well as an emotional experience for a lot of couples, not knowing what's happening in the background and trying to understand and coming to terms with it, as well as trying to find out reasons which can be something which we can change to help them in their journey to make it happen for them. So, our discussion around recurrent miscarriage is going to be split into definition, what you say or what you define as recurrent miscarriage. It would involve what investigations are done, and it will involve treatment. So what is the standard treatment available? What are the options? And obviously, if you know what is there in the presentation, this is all evidence based. So this is not a personal opinion. But obviously, where it's a personal opinion and we deviate from what is evident, then I will tell you at each step about what we are doing differently compared to what evidence suggests, and why we may be doing it, or whether we should change practice and we should not do it at all. So that is something which can come later. But the idea is to know what the evidence is with regards to investigation. And the idea is also to know what treatments are available for recurrent miscarriage, or what treatments are not available sometimes when no reason is identified. Okay. So what is a recurrent miscarriage? A diagnosis of recurrent pregnancy loss can be considered after the loss of two or more pregnancies. So two pregnancies is the European and the American definition. The British definition is three miscarriages. So when do you investigate? If there are three miscarriages, you will consider investigating. But as per the ESHRE or the European Society as well as the American Society, they say that two miscarriages is where you would trigger the criteria for referral or for further investigations for any couple. So two miscarriages is where I will discuss everything about, because in our fertility setup, we see so many women with two miscarriages, and more often than not, if I see them or if the nursing team sees them, I would suggest that more often than not, we consider investigating them for recurrent miscarriages just to find out and reassure them. There is a good chance that you do investigations, everything may come back as normal, but it is about reassuring them that there is nothing wrong, and it is just that it's just that it could be a one-off, that it has happened twice, that they have unfortunately not managed to continue the pregnancy. Now, recurrent miscarriage means it should be with the same partner and it should be consecutive. So if say somebody had one miscarriage with the previous partner and then one miscarriage with a different partner, I wouldn't label it as recurrent miscarriage. So when you say three miscarriages as per the British definition, it should be three miscarriages with the same partner, and it should be consecutive. So if they have two miscarriages, then they have a child, and then they have a miscarriage, it won't be classified as recurrent miscarriage. But obviously, we have a low threshold to investigate, is what the definition says. If somebody has 2 miscarriages, you are within your rights to consider investigating them thoroughly. So what do we classify as a miscarriage? Okay. So pregnancy loss is defined as spontaneous demise of a pregnancy before the fetus reaches viability. So we say viability is somewhere around 24 weeks. So 23 plus 6 weeks is where we would classify any loss up to 23 plus 6 weeks as a miscarriage. If it happens in the first 12 weeks, you would say it's an early miscarriage. If it happens between 12 and 24 weeks, it's a second trimester miscarriage. So reasons for first trimester miscarriages and second trimester miscarriages may be different. With first trimester miscarriages, the most common reason is abnormality in the embryo or a fault in the embryo. That is what evidence says. Most of the times, pregnancy losses happen because of a fault in the embryo. 80-90% would be most of the time because there is a problem with the genetic makeup of the embryo. And that is why generally early pregnancy scans are not done before 11 to 14 weeks. Because if some pregnancies are not normal, people will lose them even before that. So doing additional scans will not be helpful. And the other thing is there will be quite a few pregnancies which people will not know about because they have had no scans or any intervention to know that they were pregnant. But those happen because of faults in the embryo. Now, second trimester miscarriages can happen due to many reasons. It could be not necessarily a fault in the embryo, but it is more likely due to sometimes shape of the uterus. So abnormalities in the shape of the uterus, like bicornate uterus, unicornate uterus, septate uterus. So those variations in say, shape which we see on a 3D scan may be one of the causes of miscarriage. Sometimes it could be because of weakening of the cervix. Weakening of the cervix can happen after a full dilatation cesarean section, which is the most common cause nowadays because the cesarean section has become more common. So any cesarean section which is done at full dilatation may weaken the cervix for future pregnancy. It can also happen due to infection, second trimester miscarriages. And sometimes it could be because of other reasons like fibroid or septum or other uncommon reasons why second trimester miscarriages happen. So with second trimester miscarriages, sometimes there is the option of screening the cervix to check if the cervix is weak. So screening for cervical length is offered from 14 weeks onwards. So if somebody is having a repeated second trimester miscarriage, then there is a program through the obstetric unit where we offer them scans from 14 weeks to check the cervical length. Any cervical length about 2.5 centimeter is considered to be normal. So we monitor the cervical length by doing weekly scans up to 22, 23 weeks to find out whether the cervical length is changing or shortening in any way. If there is a reduction in cervical length below 2.5 centimeters, then in such women, we may consider doing a cervical stitch or giving them progesterone pessaries to decrease the risk of the recurrent miscarriage. But that is a discussion which they will have in the obstetric clinic. I'm not here recommending one or the other. I'm only telling that these are the interventions which are possible in second trimester miscarriages based on medical guidance by the obstetric team. Okay. So that's about the definition about recurrent miscarriage. Okay. So women should be sensitively informed that the risk of miscarriage is that the risk of pregnancy loss is lowest between age 20 and 35 years. Okay. Beyond age 35, that could be an independent risk factor for miscarriage. Women should be informed that the risk of pregnancy loss rapidly increases after the age of 40. So strong evidence. Okay. Stress is not is not a contributing factor always to say that this is the reason for recurrent miscarriage. Okay. But smoking may influence the increase the risk of miscarriage. Alcohol more than 2-3 units a day can increase the risk of miscarriage, and extremes of BMI. Any BMI above 30 or lesser than 18 could be contributing to miscarriage. So that's what you need to be aware of. So that when you see new patients, that time obviously these are factors which you need to keep in mind as probable causes for miscarriage. So investigations are done after the third miscarriage, but in fertility patients, we consider doing it after the second miscarriage. Generally, common investigation which is recommended is that from the third miscarriage onwards, we send the products of pregnancy for genetic testing. So that's not what we do here. But the recommendation to the couple after two miscarriages is that if you happen to unfortunately have a third miscarriage, then you need to contact the early pregnancy unit via the A&E. So they will need to get the products in via the A&E to get those tested and sent for genetic testing. The genetic testing times presently are say 4 to 6 months. Previously, they were 2 months for quite a few years, but now for some reason they are prolonged. And if the genetic testing shows that there is a fault in the embryo, then obviously there may be reason to do the same genetic testing for parents to find out if it's a genetic problem from either of the parent which is transmitted to the embryo, which could be a cause of miscarriage. So that is the only time that parental karyotype will be done, when they have a fetus which shows that there is an abnormal genetic karyotype in the fetus. Okay, if we just send the investigation for parents just as a part of recurrent miscarriage screen, like how we used to do 3, 4, 5 years ago, then those investigations will be rejected. So you need to be aware that the fetal remains from the third miscarriage need to be sent to investigate, or say they have not been sent for the third one, then for the fourth one you should send. So they need to be sent to find out if they show any flaws before that can be offered to the couple. So the HT guideline says that they don't suggest, they suggest not to screen for hereditary thrombophilia. So we do the testing for hereditary thrombophilia at our place to investigate cause of miscarriage. They say that it is done only in the research context, but obviously the way we act differently is that there are only so many limited investigations which we can do on the NHS. So we generally try to offer whatever we can, even though sometimes the evidence may be scanty, that may not be a common reason for miscarriage. The other common reasons for miscarriage are antiphospholipid antibodies. So you need to do a lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein antibodies. So when you tick mark the antiphospholipid antibody screen on your EPR, so not just the thrombophilia screen will include lupus and other coagulation factors, but you also need to click the antiphospholipid antibody marker on the recurrent miscarriage screen. So it does come up on the EPR separately. So that includes all these tests. So those tests are routinely offered by us when we investigate for miscarriages. So that is what all is available when we do the testing here in Yorkshire Fertility. Anti-nuclear antibodies may be considered for explanative purposes. We do anti-nuclear antibody testing. That is again available through us, even though the evidence is not very strong. We do thyroid screening test, thyroid stimulating hormone, and thyroid peroxidase antibody. So that is again recommended. So that is part of the standard recommendation. So these are all standard investigation which we do here in Yorkshire Fertility, or they are available on the NHS for us to do it, to help couples find out the reason why there has been a miscarriage and see what we can do differently or better to improve the chances. So all women with recurrent pregnancy loss should have an assessment of the uterine anatomy. Okay, so that is something which is basic. So here, when we screen for any fertility patient, we do ultrasound scan to check the uterus. So they need to have a screening done for uterine anatomy. The preferred technique to evaluate the uterus is a transvaginal 3D scan. So this is not because I do 3D scans, but this is what ESHRI says, that the preferred modality to investigate recurrent miscarriage is a 3D ultrasound, which has a high sensitivity and specificity and can distinguish between a septate uterus and a bicorporeal uterus. Septate means a uterus which has a single cavity but has a septum in the center. Bicorporeal uterus means there are two separate uteruses which are fused in the center. Okay, so a septum can be removed with surgery, but a uterus which has two halves which are fused in the midline, that can't be corrected with surgery. Or I can put it that way, it can be corrected with surgery, but that surgery doesn't improve outcome. So that's not for surgical correction. If the question is, are we going to improve the chances that the pregnancy is going to continue if we do that? No, it doesn't. So technically that is the difference. So it is very important for us as a clinician to know whether when you see a partition or two separate cavities, either is it a septate uterus or is it a bicornate uterus which is fused to varying degrees. Because a septate uterus is something which we can send for correction to a hysteroscopic surgeon in Calderdale who can then do a certain procedure to correct that septum to make the cavity congruent. Okay. Sonohysterography is more accurate than hysterosalpingography. Now, hysterosalpingography is done to check the fallopian tube, but because we put a dye into the cavity of the uterus, we also get to see the shape of the cavity of the uterus when we do a hysterosalpingography. Esri has recommended that putting in saline. So say when we are doing a scan, we put some saline in with the same HSG catheter into the cavity of the uterus. And that saline will act as a contrast because when you do a scan, you ask the patient with a transabdominal scan for a full bladder because that contrast between the bladder and the uterus helps you identify the uterus and the ovaries better. So same way, if you put some saline inside the uterine cavity, you will be able to demarcate the uterine cavity better and you will be able to check the shape of the cavity better. So that is something which is recommended. So it is something technically which we can do here if we have the catheters and we have the saline, but we need to get it approved before we can do it. But that is something which is possible, and you can marry that with a 3D image. So instead, they say that 2D is okay when you are using saline because the saline gives you the third dimension. So when you put saline inside the cavity of the uterus, even a 2D scan will become three-dimensional because now the uterus is not that way. Uterus has expanded with the saline into a ball. So you can image it in all the three planes, even with a 2D machine. But if you have a 3D image, it will further improve your accuracy to find out about the shape of the cavity. So MRI is not recommended as the first line option. So MRI is as good as a 3D scan, but the 3D scan is dynamic compared to the MRI, which is an image. All women with recurrent pregnancy loss could have a 2D ultrasound to rule out adenomyosis. So adenomyosis is something where you say that you have done a scan and you see some bright marks in the uterine musculature or the myometrium, and you say that that is adenomyosis. Adenomyosis means the endometrium, which is coating the lining of the uterus, it is growing inside the uterus. So it is like endometriosis, but in endometriosis, the endometrium is going to grow outside the uterus on the ovary, fallopian tubes, bowel. But in adenomyosis, the same endometrium is growing inside the uterus. Now, if you can see that the endometrium is brighter than the muscle wall of the uterus, so you can see a bright endometrium stripe, and that is how you measure the endometrium. Now, imagine if the same endometrium is growing into the wall of the uterus, you will find that the wall of the uterus is also similarly bright like a light bulb. And that is what you will say is adenomyosis. So that's why it is an ultrasound diagnosis or a histological diagnosis. You can't diagnose adenomyosis without taking a biopsy. Only when you do a hysterectomy and you send the specimen for biopsy, it will come back as showing adenomyosis. But you can screen for adenomyosis by doing an ultrasound scan, where the ultrasound scan is going to give you that light bulb appearance or bright appearance of the myometrium, which is sign of adenomyosis. And they say here that adenomyosis is one of the risk factors for recurrent miscarriage. Can you do anything about it? No. Because it changes the functioning of the endometrium. It's like endometriosis. It's an inflammatory process. Any inflammatory process is going to reduce implantation or reduce the potential for implantation. If a Mullerian uterine malformation is diagnosed, further investigation include investigation for kidney and the urinary tract, because the development of the uterus, when the development of the uterus happens when the woman is 6 weeks old, 5 to 6 weeks old. So the uterus forms at the age of 5 to 6 weeks age in the mother's womb. 5 to 6 weeks. So at 5 to 6 weeks age, the different cells from two sides come and join in the center. The uterus forms in the form of two bulbs which join in the center at 6 weeks age. And then by 9 weeks, the architecture changes into the normal uterus as well as the cavity forms. But if this fusion between the two parts which grow during embryogenesis at 6 weeks age inside the mother's womb, that fusion doesn't happen, there will be two uteruses and two cervix. If the fusion is partial, then there will be variation, like bicornate uterus, septate uterus, whatever variation. And the kidneys also have development from the same cells which come and join together. So if there are abnormalities in the uterus, then they are associated with abnormalities in the location of the kidney, or presence or absence of the kidney, or shape of the kidney. So single kidney, double kidney, duplex kidney, kidney in the pelvis, abnormal location of the kidney, one ureter, two ureter. So those are variations.
So that's what I've got. I've got an ectopic kid there.
Yeah.
So what's that? So that was hard. Yeah, obviously the uterus is fine.
We are recording this. Yeah, sorry. Yeah. Okay, sorry. Okay. Okay, sorry. Yeah, so next slide. In couples with recurrent pregnancy loss, it is recommended to assess the lifestyle in the male partner. I'm just going to interrupt for 1 minute, okay? Yeah, sorry. Okay, so in couples with recurrent pregnancy loss, it is recommended to assess lifestyle in the male partner. Okay, paternal age, smoking, alcohol consumption, exercise pattern, and body weight may also play significant roles in miscarriage. Assessing sperm DNA fragmentation in couples with recurrent pregnancy loss could be considered for diagnostic purposes. So, sperm DNA fragmentation is a test which is available in the market. It is quite expensive. I don't know what the current cost is, but I believe it is expensive, and it sometimes is one of the tests which is done for recurrent miscarriage. Now, it tells us about the fragmentation of the sperm, which is DNA damage. And if there is a lot of DNA damage, then obviously that sperm may be one of the reasons for recurrent miscarriage. But obviously, if you ask me, is there any treatment? Sometimes the treatment is antioxidants, but obviously it is very difficult to say what is the treatment in such situations. So if some couple ask for DNA fragmentation test, then obviously it is something which they can do, which is not done here, but I think Care Fertility do it. But is there any treatment available? If you find out the problem, I'm unsure that there is no evidence-based treatment available at the present time. But obviously, the other option would be to use the donor sperm if you find that a lot of sperm DNA fragmentation is there. But that may not be acceptable for someone who has a normal sperm quality, who has normal sperm quality, who may want to continue using his own sperm to have a child which has a genetic makeup of their own. So what is not recommended? Okay, so which investigations are not recommended? So when I say, so up till now we discussed about what is recommended. So now we also need to know, because people or patients, if I will not say people, the couples will do their own research and they will come to you with a lot of information. So what is not recommended? Ovarian reserve testing is not routinely recommended. We do it here because that is a part of our standard investigation. We think that sometimes low egg reserve may be one reason for miscarriages. But obviously that is not routinely recommended in a scenario where you're just investigating for recurrent miscarriages. Assessment of PCOS, fasting insulin and fasting glucose, is not recommended in women with recurrent pregnancy loss. So I'm not answering the question why. I'm only letting you know that this is not recommended. Okay, because that is not evidence-based. PCOS screening, insulin resistance is not recommended. Prolactin testing, not recommended. Again, our luteal phase insufficiency, testing, homocysteine levels, LH level testing, and androgen testing is not recommended as a part of standard investigation for recurrent pregnancy loss. So that's what the H3 guideline says. Okay. So treatment to increase live birth in recurrent miscarriage. All couples with results of an abnormal fetal parental carrier should receive genetic counseling. So if the karyotype of the fetus is abnormal when that screening has been done, then obviously to get more information to advise the couple, ideally they say that they need to be referred for genetic counseling to help understand the why and get more input on what intervention can be done going ahead to improve the success rate. All couples with results of abnormal fetal parental karyotype may be informed about the possible treatment options available, including their advantages and disadvantages. So what they mean when they say this sentence is that intervention is pre-implantation genetic diagnosis. Pre-implantation genetic diagnosis is to exclude the presence of any abnormality which is passed from the parents to the child. And there is also another thing called as pre-implantation genetic testing, PGT. So PGT is what we normally do here, and that is just to make sure that the embryos are not aneuploid. Aneuploid means not having an abnormal karyotype. So with PGT, which is what we routinely practice here when we talk about PGT or testing the embryos, we talk about PGT, not PGD. PGD is in somebody who already has the diagnosis of a genetic problem. PGT is testing of embryos to find out whether they are karyotype normal, to consider them for a transfer in the hope that a genetically normal karyotype will improve the chances that the pregnancy will continue and not miscarry. Okay. So that is again not evidence-based, but that is a strategy which sometimes some units may use or the clinician may use to optimize the chance of treatment working. The reason why it is not evidence-based is because research has shown that even some genetically tested embryos which have been deemed abnormal have resulted in a normal pregnancy. Okay, so testing embryos, finding it is normal, that is a positive, but excluding embryos because they are abnormal may result in you excluding embryos which may have resulted in a pregnancy. But the testing is not 100%. Testing is more than 90%, 95% is what they quote. Because it is not 100%, we need to let the couple know that this is the disclaimer or limitation behind doing something which may not necessarily be 100% accurate. For women with hereditary thrombophilia and a history of recurrent pregnancy loss, we suggest not to use antithrombotic prophylaxis unless in the context of research. Okay, we use Fragmin for everyone. So it is empiric treatment. So again, it is, you don't give Fragmin, there is no evidence to give Fragmin. That is what Dr. Jacob has said, that obviously you may want to reduce, but generally patients want an intervention. They would like to take something with limited benefit or no benefit rather than not take something, especially when you do further investigations and there is a possibility they may be lupus or antiphospholipid antibodies which may be helped with Fragmin. So that is the argument behind giving Fragmin or not giving Fragmin. For women who fulfill the lab criteria for antiphospholipid syndrome and a history of 3 or more pregnancy losses, we suggest administration of low dose aspirin, 75 to 100 milligram, starting before conception, and prophylactic dose of heparin or low molecular weight. So if somebody has antiphospholipid antibody, then you give Fragmin and aspirin you can start periconceptionally. Overt hypothyroidism arising before conception or during early days. So anybody who is hypothyroid needs thyroxine treatment. So we do it for everyone. But obviously that needs treatment because that may be a cause of recurrent miscarriage. Euthyroid women with thyroid antibodies. So again, you may do testing for thyroid and you may find the thyroid function is normal with a TSH of less than 2.5, and there may be thyroid antibodies. So if there are thyroid antibodies, you don't need to treat with thyroxine. But the TSH, if it is more than 2.5 and thyroid antibodies are present, then in some cases, if there is a clinical history like recurrent miscarriage, we would generally treat with thyroxine to optimize the function. We say TSH up to 4 is normal. But TSH between 2.5 and 4, even though it is normal for the woman, for her own health, from the miscarriage point of view, sometimes we do treat if there are thyroid antibodies present. Now, if the thyroid antibodies are not present and the TSH is between 2.5 and 4, then we don't need to treat with thyroid. Okay. There is insufficient evidence to recommend the use of progesterone to improve live birth rate in women with recurrent pregnancy loss and luteal phase insufficiency. Okay, so we don't give progesterone randomly to everyone who has a recurrent miscarriage because there is no evidence to suggest giving progesterone just for the sake of recurrent miscarriage without any positive finding. There is insufficient evidence to recommend HCG injection, which is ovitrial injection to improve birth rate. So that there used to be previously HCG injection which were given weekly to give luteal support, but that's no longer recommended. There is insufficient evidence to recommend metformin to supplement in pregnancy to prevent pregnancy loss. So there is no role of metformin. Preconception counseling in women with recurrent pregnancy loss could include the general advice to consider prophylactic vitamin D. Only one small RCT showed no benefit of using hysteroscopic septum dissection to reduce the rate of pregnancy loss. So whenever we notice a septum or a fibroid inside the uterus, we don't jump and do surgery. We generally would allow first to see it happens naturally. Only in certain clinical situations where we feel that it might be interfering with fertility or maybe a genuine cause of miscarriage, we will consider intervening and removing the septum or removing the fibroid. Uterine reconstruction is not recommended. Metroplasty, which is joining two halves of the uterus, if somebody has two uterus, is not recommended. Okay. Insufficient evidence supporting hysteroscopic removal of submucosal fibroids. So when we see submucosal fibroid, not all fibroids need removal because it is not as easy as removing a fibroid or a septum. You may think it is there, why not remove it? Because it's not right there. It was not supposed to be there. But obviously, when you do surgery to remove a septum, you do surgery to remove a fibroid, you may end up causing infection, scarring inside the uterus, synechiae inside the uterus, which is Asherman syndrome, and that may further compromise fertility. So you may end up doing a surgical intervention in the good faith that this is going to help, but that may not always help. And that may be sometimes one of the causes of miscarriage or failure to conceive. So as such, when you see something, you don't necessarily always need to operate. So the decision is not about always operating. Okay, generally, if there is a clinical consensus between 2-3 clinicians and everybody feels that this may be beneficial to the couple, then there will be a discussion with the woman whether she would like to consider this, understanding the limited benefits as well as sometimes the drawbacks. Because surgery is not always the best thing, as long as limitations are understood and we understand that things may still not be perfect. So that's why whenever we see fibroids, whether they are outside the uterus, inside the uterus, we don't always jump and do surgery. And you may have seen that women have larger fibroids and we don't end up doing surgery and we encourage them to conceive and finish their pregnancy before we consider intervention. But there may be certain cases where we may need to intervene, but that is a complex decision. There is no yes or no or right and wrong. It is just about discussing with the woman, taking second, third opinion from other consultants about what is the right thing to do. And only when everybody has reached a consensus and we find that this is something which may be beneficial, we then offer certain intervention to the couple. Okay, there is insufficient evidence to say that removing intrauterine adhesions are going to improve pregnancy outcome. Okay, but sometimes we do consider removing them as they are a cause of difficulty with conceiving rather than just miscarriages. Women with a history of second trimester pregnancy losses should be offered serial scans, which is what I discussed with you. In women with singleton pregnancy and a history of recurrent second trimester loss attributable to cervical weakness, CERCLA should be considered. Okay. There is no evidence that this treatment increases perinatal survival. So CERCLA can be considered. So you may close the door if the door is weak, but that doesn't mean that the pregnancy is always going to continue. Sometimes it may still end in a miscarriage. It has not always shown to improve survival, but obviously that is an intervention you may consider in certain women. Couples with recurrent pregnancy should be informed that smoking, alcohol consumption, obesity, excessive exercise could have a negative impact on their chance of live birth. Okay, so we discussed, this is just advice which we give to everyone. Normal body weight, limited alcohol consumption, 2 to 3 units, and normal exercise pattern. Okay, not a large amount of exercise. Okay. Then there is no evidence to support sperm selection by physiological intracytosis. So there are certain sperm selection techniques which are available with ICSI, which were previously quite in demand. By thinking that these additional procedures to select the sperm may help reduce the sperm-related cause of miscarriage, but that's again not evidence-based. Antioxidants for men have not been shown to improve live birth. Then certain experimental experimental treatment like lymphocyte immunization and all shouldn't be recommended. Repeated high dose intravenous immunoglobulin very early in pregnancy may improve birth rate in women with 4 or more unexplained recurrent pregnancy, but that is not something which we offer here. Glucocorticoids are not recommended as treatment of unexplained recurrent pregnancy loss with selected immunological biomarker. So it's again not empiric treatment like how we give it fragment. Heparin or low dose aspirin are not recommended as there is evidence that they do not improve the live birth rate in women with unexplained recurrent pregnancy loss. Low dose folic acid is routinely started periconceptionally to prevent neural tube defects, and it has not been shown to prevent pregnancy loss in women with unexplained recurrent pregnancy loss. So we give 5 milligram sometimes, but obviously it's not again evidence based. Vaginal progesterone may improve live birth with 3 or more pregnancy losses and vaginal blood loss. See, that vaginal blood loss is important here because previously the investigation is that it doesn't recommend progesterone for miscarriages. That is a statement. Here it says if there are more than 3 losses accompanied by blood loss, then there is a role of giving progesterone to reduce the risk of miscarriage. So only if there is any bleeding in early pregnancy, fourth pregnancy onward, you can give progesterone that has been shown to improve outcome. Okay, there is insufficient evidence to recommend intralipid therapy. So previously, if the nurses here who have been here long, they may be aware that sometimes we used to refer patients for intralipid infusions, which used to happen through Manchester privately, but they have not been found to be evidence-based, and they have resulted in severe anaphylactic reactions as well as complications with women. So the RCOG doesn't recommend giving intralipid infusions or has never recommended, and actually we should avoid giving them. Okay. So there is no evidence to recommend granulocyte colony stimulating factor in women with recurrent pregnancy loss. There is no evidence to recommend endometrial scratching, our favorite intervention. So there is no recommendation that it is going to reduce the risk of miscarriage. If women with recurrent pregnancy loss ask for vitamin supplement, they should be advised on multivitamin supplement. They are safe in pregnancy. Multivitamins can be taken which are safe in pregnancy, but again, it is not to do with reducing miscarriages. Okay, so any questions, anything anyone wants to ask online, or anybody who is attending online, anyone wants to ask any questions in the live audience as well as online?
Is it still like a 3 to 4% chance of miscarriage? Is that what?
3 to 4%.
Yeah. One in 3 to 4. I mean, 1 in 3 to 4 pregnancy blended miscarriage. Is that still the statistic?
So 1 miscarriage, 20%, 2 miscarriages, 33%, 3 miscarriages, 44%. And fourth miscarriage, I don't know, but first 3 miscarriages, those are the percentages which you can tell couple. So this is evidence based. So the important thing is not that there is a 44% chance of miscarriage happening the third time. The important statement is that there is still a more than 50% chance that they will conceive and have a baby. So that is how you would say.
Yeah. Hi, Mr. Lakshmi and Deepika. I'm attending this. Thank you for your lecture. Just want to ask you a question. We get a lot of women we see in early pregnancy unit when they have had IVF conception. done from outside the country, from outside UK, and they come to us wanting to refill their progesterone prescription or heparin prescription, low molecular weight heparin prescription, and there is no evidence of any recurrent pregnancy loss in them, and they insist that it was told to them. What do we do in such cases?
Yeah, very simple. You give it to them, but they have to pay for it.
Oh, okay.
So we are allowed to prescribe them if they are having a evidence or a letter from the clinician saying that they have to continue progesterone throughout pregnancy or fragment throughout pregnancy or progesterone up to 12 weeks or fragment till whatever time, you support them. But
Okay.
they have to pay for the prescription. So you can issue a private prescription, let the lab know there is a cost for pessary. Pessary cost around £1 or something per pessary. Same way there is a cost for fragment. You can send a paid prescription for the pharmacy, and the pharmacy can bill them for the cost of medication, and you give them the medication.
Okay. Thank you.
Okay.
Yeah.
So don't say no. Don't say no. You want to support them. You want to support them because obviously they have gone from pillar to post as well as abroad. So you want to support them.
No, we don't say no, but I don't give them
Yeah.
private prescription. I give it on NHS, but sometimes I feel that it's not right thing that I'm
Yeah.
doing.
So it is right if they are charged, because it's empiric treatment which they want because they had private treatment. So anyone who has private treatment, they don't get these add-ons on the NHS. But obviously, if they are taking fragment for antiphospholipid antibodies, you will give that on the NHS, because that is medical reason for that. But obviously, if
Yes.
it is empiric treatment, you have to just ask the lab, and then the lab will dispense them based on the cost.
Okay.
And you make the patient aware. More often than not, even if you do that much, the patient will be very happy with you.
Okay. Yeah, makes sense. Thank you.
As per the HT guideline, they have not mentioned anything about natural killer cells at all.
Yeah.
They have not mentioned natural killer cells for miscarriage. Natural killer cells investigation is done for implantation failure, not for miscarriage. So implantation failure is where they have had more than 3 normal, good quality embryo transfers, and there has never been a pregnancy as opposed to there being a miscarriage. So that recurrent natural killer cell information you will get in the add-ons in HFEA website, where I don't think it is a green or a amber add-on. It is a red add-on. Outside research basis, it is not green. Yeah. Yeah. Anything else you want to ask? Anyone wants to ask? Yeah. Okay. Thank you very much, everyone. Bye. Bye.
Did you ever get to the bottom of what caused the miscarriage?